This conference will now be recorded.
Massive proteinuria, hypoalbuminemia, hypercholesterolemia, and edema. So this massive proteinuria has got so many definitions. Most commonly used are 40 milligrams per square meter per hour or 1 gram per meter square per day. Because these are daily requirements, we use a spot urine specimen. That is, spot urine protein by creatinine more than 2 is an indication of a nephrotic. Now, coming to the what is the cause? What are the probable causes? If you look at this simple pie chart, see, bulk of it, majority in children are idiopathic. There is nobody knows exact cause why they develop. Then so many theories will come actually. And about 10%, approximately less than 10%, they come with a known cause. The known causes are plenty. So many causes are there. But for practical purposes, the commonest cause of nephrotic syndrome in children is a idiopathic one. So this is the breakup. In this idiopathic form, the general incidence is 1 to 3 cases per 1 lakh population under 16 years. 10 lower than in adults, because adults very rare nephrotic syndrome. Male to female ratio borderline male preponderance children. When it comes to adolescents, no preference, almost equal same. MCNS means minimal change in nephrotic syndrome. What is minimal change? We'll go subsequent slides we are going to know. So the minimal change peaks between 2 and 5 years. 92% of these will experience remission with their disease when treated. That means they're all very good prognostic. You treat them, they recover. Adolescents, but however, they require more aggressive treatment because older the child, that means the more complicated forms may be much more. Now, you can classify nephrotic syndrome in a different ways. Actually, I'm showing the 4 possible ways how you can differentiate it. First and foremost is etiological classification, where, as I said, I already mentioned, whether there is a cause or no cause. When it is no cause, you identify that idiopathic, we call it as a primary. When you know certain causes, what are the known causes will subsequently, then it becomes a secondary nephrotic. So this is the most commonly used the classification of this. And the second is pathological. That depends depending upon the biopsy. Actually, not even actually simple biopsy, only electron biopsy, microscopic can only tell all these things. So according to this, the 4 classifications, most common nephrotic syndrome are the minimal change. Most common variety is the minimal change in nephrotic syndrome. The second is focal segmental glomerulosclerosis. The third is membranous nephropathy. 4 is membranoproliferative glomerulonephropathy. The 4 pathological causes. We are mostly dwelling on this minimal change today, but for idea's sake, we are going to see what these other 3 are also. The third is as for the inheritance, whether it is genetically transmitted or actually acquired disease. Acquired means most of the secondary becomes acquired. Even the idiopathic also acquired only, it's not a genetic. There are few genetic syndromes are there. At the end of it, actually, I just give a glimpse of them. Okay, we are not going much. And the most practical day-to-day is, but as a clinician, what is required is a therapeutic classification. This is the therapeutic classification. This is very important. What is the therapeutic response is? Whether it is responding to treatment or not, whether it is responding to steroids, that is steroid sensitive. It's not responding, or is steroid resistant. It is responding, but also the moment you stop, it is coming back. That is called the steroid dependent. So these are the 3 categories of the based on the clinical response. Very important. So most of the, as a clinicians, we are seeing because about this one, and as a treatment physician, this is the most important. So these 2 are very important for us. Speaking of idiopathic nephrotic syndrome, as I said, this is 90% of the cases are idiopathic nephrotic syndrome. So we shall have a little more clarity about this. Majority of them is minimal change in nephrotic syndromes. The second common is the focal segmental glomerulosclerosis, 10%. Membranous nephropathy is 1%, and all other membranoproliferative or secondary causes comes under membranoproliferative glomerulonephritis. So again, we are discussing mostly about the minimal change today. The word about the secondary, I said actually 10% only with some causes, known causes. So this was small fraction of this 10% of the total, but there are got several classifications. But examiners do ask, tell me what are the secondary causes of the nephrotic syndrome. So idiopathic, everybody familiar, you read very well. But In case secondary, when do you suspect the nephrotic syndrome secondary? So these are all the possible etiological factors you come across. The first is the vasculitis, various types of vasculitis, vascular diseases like systemic lupus erythematosus, inoxanic purpura, rheumatoid arthritis, vaginous granulomatosis, good posture syndrome. These are some of the examples. All these vasculitis, because renal vessels are also involved, and ultimately lead to proteinuria and nephrotic syndrome type of features. But sometimes a mixed feature, nephrotic combination features, there we come across this one. That is becomes a big differential diagnosis problem there. So there is a metabolic disease like amyloid disease, not so common in children, but in adults is very common. Myxedema, there is post hypothyroidism will lead. Some of the cases of diabetic nephropathy also may lead to nephrotic syndrome like this. Some infections leading to nephrotic syndrome. This is a very favorite question of many examiners, because tell me some infections which might lead to nephrotic syndrome. So you can divide into parasitic or viral and other infections. So examples of virus are various types of hepatitis, cytomegalovirus, HIV virus, and syphilis parasite, and there is the treponemal. And shunt nephritis actually is not an infection, but post-infection. Actually, whenever you do the repair operations, then they are supposed to develop a nephritis following a shunt operation for cardiovascular disease or something like that. Parasitic examples is Plasmodium malaria, not the Plasmodium vivax or actually falciparum. They are not doing. The Plasmodium malaria, which is prevalent in African region, it is known to produce nephritis, but not our falciparum and vivax. Please remember that only one from so far identified is leading to this, and toxoplasma and the parasite. Next, drugs causing nephrotic syndrome. This is also a favorite question for most of the examiners. So heavy metals like gold, mercury, and some of the drugs anticonvulsant like ethosuximide, and it is chelating agent like penicillamine, antidepressant like lithium, and many of the newer non-steroidal anti-inflammatory drugs like the diclofenac, also things like very good. So some of the, at least you remember the anti epileptic drugs and heavy metals and penicillamine reduce. You remember at least 3 or 4. Malignancies, yes, lymphomas and carcinomas may lead to, and there are congenital inherited forms. As in the classification itself, I said no. Examples is Alport syndrome, nail patella syndrome. These are things. Just for example, we'll discuss later. Now, this is the minimal change. What do you mean by minimal change? Minimal change is, this is the diagrammatic explanation when we do the biopsy. Here is a glomerular, as you can see, and the epithelial normal structure is shown in the above picture. This is a normal one. Okay. And what here you can see small processes. These are all the epithelial, what is called the foot processes. You see, these foot processes or the epithelial cells have these foot processes. During minimal change, they get effaced because these foot processes are gone. Actually, they become a flat. So because of this, what happens? This is the pores are there in between the epithelial cells. These pores, these foot processes prevent the coverage. But in the absence of this, the pores actually, maybe literally they becomes like a leaking membrane. So the minimal change means this minimal change you cannot see in the microscope at all. That's why it's called the minimal change. You can see only the electronic microscope. You can see here the normal phenomenon, and here you see the basement membrane. Actually, the epithelial they do not have it. They almost become a flat. So you don't see this type of foot processes. So the absence of foot processor makes it a minimal change in nephrotic syndrome. And actually, it's not simple absence of this thing. There is also electrical changes induced by this change. So that is the main pathology for the development of the proteinuria, especially selective proteinuria. So proteins of a small molecular volume, they just tend to slip off. So that is what is happening in this minimal change nephrotic syndrome. Okay. Now, this is the most a little more diagrammatic in the examinations, because you can't draw all these diagrams, maybe difficult, but you can definitely draw a simple diagram like this. Always remember, whenever you depict diagrams, they will fetch marks more actually. Instead of writing a 10 lines, you can just show this is the normal filtration, this is how actually the adhesion molecule is there, this is the basement membrane at different color. You show, if you got a color pencil, it's okay, you just gray it at least. So these are the endothelium is there, and these are epithelium. Endothelium is what is one is towards inside, epithelium towards the outside. So the outside one has got the foot processors actually. And what happens? These foot processors, the elevated ones are called the foot processor. These are So they became flattened. Here, what happened? You see, this is effacement. Some of them, at least, some of this is a normal one. This is a destroyed one. So because of this effacement of these foot processors, the contents inside the glomerular cavity, they just slip off and go off into this lumen, actually, into the urine. So albumin, like small molecules, like albumin molecules, which are small enough, they just pass through. So globulin molecules, which are big enough, they may not be able to pass through. So this is called the selective proteinuria. Only small molecular ones, they just go up and small, they remain in the urine. Like that, slowly, all these small molecular proteins will leak into the urine. So this type of diagram you can always draw. It will fetch you very good marks. Okay. Yeah. What is the mesangial proliferation? This is actually next stage is another way pathology is mesangial proliferation happens. So this is the mesangium area. This is called as a this is the if you sorry, where is my pen? Yeah, this is the glomerular basement. This is the mesangium area because where you see there are so many cells have come here and usually supposed to be narrow area. You can see that it is usually narrow, this such a narrow. Instead of this mesangium becomes very, very broad in here. So clinically, when you see light microscope, it looks like this. So, but these patients also nearly 50% respond to your treatment. That is the beauty of this. So 50% only respond, whereas minimal change, this type of thing, where almost 10% they respond to the steroid therapy. And the focal segmental glomerulus, the next type of pathological change I just mentioned is what you see in the electron microscope. See, this focal only a part of the glomerulus is destroyed. This is the sclerosis has happened. So focal segmental glomerulus looks like this, and in the diagrammatically represent means this type scarring actually is focal scarring, not the entire glomerulus is not affected. So usually this type of sin HIV infection or post-vesicourethral reflexes and drug addicts also sometimes is the type of this thing, and ultimately lead to end-stage glomerular. There is chronic renal failure. So this the prognosis is not that good actually. They don't respond to steroids. And the last variety is membranous glomerular nephropathy, very, very less common, only 1% occurring in children, very, very common. But this type of thing may be seen in the post-infection, like post-hepatitis syndrome, or a Sjogren syndrome, or SLE type, and syphilis, sarcoidosis, drugs, and sarcoidosis is very unusual in children, and post-diabetes. So you see the basement membrane thickening, you can see in the microscopy. So this is the thickening of the basement membrane. In a diagrammatically, if you want to see, this is a normal structure, heterostology. So the basement membrane, you see, you can't see it here. So here it is so much of thickness. So this is a thickened basement membrane characteristic of membranous nephropathy seen in this thing. This is a mesangial. This is mesangial proliferation means here there is a proliferation means mesangial proliferative glomerular nephropathy. That is the difference. So this is for just your understanding. Most of the undergraduates were not troubling you much about this one. Okay. Next. Pathology, pathophysiology. What happened actually? What happens and how the disease developed? So there is an increase because protein is lost in the urine means there is increased permeability. Definitely increased permeability in the capillary wall. So which leads to massive proteinuria. Because the protein is lost, we develop what is called as hypoalbuminemia. So the minimal change most probably this is a T cell dysfunction. T cell dysfunction, alteration in the cytokines causes loss of negativity of the glycoproteins on the glomerular membrane. Usually, if you take this membrane, sorry, on one side there is a negativity. So the protein is coming out, they will be deflected away. So once it is gone, the positivity develops. The proteins which are actually negatively charged, like they get attracted, and from there they slip into the lumen. So like that, this is the problem. So it is not the just structural changes, it is the functional changes of the loss of negativity on the glomerular membrane, basement membrane, that attracts the negatively charged albumin molecules like that, and they ultimately slip out. In case of focal segmental glomerulus, there is a structural difference. Actually, here there is you can see structure is different. So there is a plasma factor by lymphocyte responsible, and there is this plasma factor is dependent upon the mutation on the what is called as a alpha actinin 4 and podosin. These are the structural proteins on the basement membrane. Their structure is changed, and that is called as a necrosis. That is for the sclerosis. And most of the steroid-resistant nephrotic syndrome, these mutations are supposed to happen in the nephrotic syndrome. S1 nephrin. This is a gene for the nephrin is one protein and podocin is the second protein. These proteins are on the basement membrane and their structure is dependent upon the NPHS one gene and podocin gene. And also WT gene is nothing but a Wilms tumor 1 gene and alpha actinin 4 gene. These are the genetic concepts actually. This one most often we are not asking, but if you write these, there will be additional points for you. If you want extra marks, you can mention genetic changes occurring in the ACTN4 gene and WT1, that is the Wilms tumor gene. All these are things developing the proliferate that is the membrane of glomerulonephritis. All these things are the concepts of these things. Now coming to the clinical features, all of you are familiar. This is the most important part from the clinical examination. So usually the children are below 6 years and between 2 to 5, as I said. 30% adolescents also may have minimal change also. But as it is, adolescents occurrence less, but when it occurs, nearly 1/3 of them may be MCNS also. Onset is very insidious, gradually childhood develops. So initial episodes and subsequent relapses may happen because of some stimulating factor. Initial first step, there may not be any stimulating factor. Stimulating factor may be insect bites or bee stings or poison ivy, also things may be precipitated, even with a minimal change also. Please remember they are not secondary. These are minimal change. Relapses precipitated by the factors precipitating relapses are these things. Okay, and you can see the child and the sarca generalized edema ascites. You can see the stria this on the abdomen show. This is from your OP guy. So this stria, that means this rapidly developing abdominal expansion develop this stria, and you can there is a pitting edema everywhere actually. And if you auscultate, there may be pleural effusion also inside. And you see this general ascites is there, pedal edema is there, genital edemas, girls or boys, and massive ascites you can see. There is a pitting edema, you can see the pitting. So, well, these are the clinical features that you see clinically. And what are the symptoms you see? Come across, patients may complain of a lack of appetite, irritability, abdominal pain maybe, and diarrhea and genital edema. These are the common things where it's bring the children. They may also tell that when the child passes urine, there is a lot of bubbles. There is a prothy, so because of the high protein content. Edema, because of the edema, it may cause a physical. The process of dyspnea and breathlessness here is it may because of the physical encroachment on the lung. There is a massive abdominal or a pleural effusion causing, or ascites pressing up because of the diaphragmatic movements, and sometimes there may be even laryngeal edema causing this hoarseness also. So the child may present any of these symptoms. Please remember all these possibilities. Chest discomfort may be because of pericardial effusion, and there may be arthralgia because of hydroarthrosis. There is a water collection inside the joints. It's not inflammation, just collection. Hydroarthrosis we call it. And abdominal pain may be because of the stretching of the parietal pleura, parietal peritoneum, because of the ascites, or mesenteric edema. So these are the manifestations. Edema may obscure signs of muscle wasting. Usually, chronically, what is happening because of the hypoproteinemia? Your muscles are using this protein. So, but even then, you may not see the malnutrition because of the edema. And there may be what is called the Merkis lines. Merkis line on the finger lines, whitish lines are the horizontal lines. So these are the common features you come across this. Uncommonly, because hypertension is not a common thing with the nephrotic syndrome. Whenever you see hypertension in nephrotic syndrome, you must suspect nephritic factors, nephrotic combinations like all the secondary type nephrotic syndromes are there. So, but rarely it may manifest in nephrosis, plain nephrosis. Gross hematuria again is not a feature of a nephrotic MCNS, but whenever you suspect the nephrotic combinations are there. Joint involvement, as in the sense it may be hydroarthrosis, but maybe some secondary traumatic. Skin rashes may occasionally, especially post-viral, all these things you may see some skin rashes. These are less common features, just remember. So clinical features, you must remember all these things first of all. Then a simple diagram just is IAP tells you how to differentiate it, because in clinics we call the child comes with a swelling of face and swelling of edema, feet and all these things. Your problem is differentiate from the nephritis with nephrosis. So insidious onset usually MCNS. Usually post-typical glomerulonephritis is much faster. It develops, of course, after the glomerular there is a streptococcal infection. It may take 3 or 4 weeks later. But when the renal manifestations are almost other, because development of edema, facial edema, passing of reddish urine, all this may be rather acute. Edema, mostly the major dominating feature in the nephrosis, whereas in the glomerulonephritis it is a reddish color. Oliguria and hematuria are the major symptoms. There may be edema, not so prominent. Oliguria always there, edema follows it. First, hematuria, all these things, then hypovolemic shock may occur in the case of nephrotic because of massive proteinuria, whereas in nephritis, it is hypertension is more common because of the pathophysiology in this because it has mechanism. Ascites may be seen both, but hypertension will lead to seizures in case of a acute glomerulonephritis. And pleural effusion may be seen in both cases. Congestive heart failure is common in the case of this thing. And renal failure is not common in either of these things. Both of these diseases have got a very good prognosis. Acute renal failure occurring either due to nephrosis or due to glomerulonephritis is unheard of. Very, very, very rare. Please remember that. So, now coming to the investigation detail, we'll talk about later on. See, dipstick is common thing. When you say 1 plus urine, it is usually tells you approximately 30 to 100. See, normally there may be 30 to 15 to 30 milligrams per deciliter, may be normal actually. This is normal. We cannot take it into consideration because what is called the Tom Horsfall protein. The total daily tubular protein, this is called the tubular protein excretion is about less than 300 milligrams. So that is mostly because of the Tom Horsfall protein. All of you are familiar. But so up to this thing, there is only 1 plus is there. 2 plus means 100 to 300 milligrams per deciliter, the concentration per deciliter. Remember, 3 plus means 300 to 1 gram. So anything above 1 gram, it will lead to massive proteinuria. This is called as a. So color changes, negative yellow. So almost bluish color in the dipstick is indication of above more than this. Based on this, we can say it is a massive proteinuria or not. So proteins lost, as I said, it is a selective proteinuria. Here, selective means small molecular volumes are lost actually. So that's why what are the small molecular albumin? This albumin is the commonest one, and thyroxine binding TBP. Thyroxine binding is also normal, very small. That's why hypothyroidism manifested second nephrotic syndrome may develop. Polycalciferol binding protein. That's why vitamin D3 deficiency also manifested. Transferrin is also small molecule. That's why loss of transferrin leads to iron deficiency manifestations. Various metal binding proteins may be lost. And antithrombin 3 and protein S, C, and protein, which is an anti-plasmolysis, the hemolysis preventers actually. That's why hypercoagulability, because once the fibrinolysis is prevented, what will happen? Hypercoagulability state develops. That is one of the common problems with nephrotic syndrome is mainly because of these proteins are lost in there, which is preventing of the thromboembolysis. Because they are lost, you may develop a thromboembolic phenomenon. So these are the selective proteins which are lost. So why are they lost? Again, the mechanism of being, because you may be asked for each symptom of each pathophysiology, there must be something behind the what is the cause. Cause of proteinuria is increased loss mostly. So what is happening? This is negatively charged sialoproteins option. So all glycoproteins. So once the negativity is lost, instead of repelling back the small proteins into the bloodstream, they are being attracted to the glomerular basement membrane. From there, they are lost. That is the most common accepted one. The loss of food processor physically may be creating a force also. There is a possibility. In addition to these losses, there may be inadequate synthesis also because the production also may be affected. Increase in catabolism, destruction, especially lipoproteins are all being disturbed because of hypoproteinemia. What it causes? It breaks down existing protein for the daily requirements of make and break on all this. So what is existing proteins are also being utilized away. So that is the destruction of the catabolism. So all these are factors for leading to the hypoalbuminemia, hypoproteinemia. And edema. What happened to edema? How does the edema develops? When there is massive proteinuria, that will lead to hypoalbuminemia. So what will happen to the plasma oncotic pressure? Decreased. And once the oncotic pressure is decreased, the transudation of the fluid into the interstitial spaces happen. So that is how the edema has developed. So this is the cycle. If you can put in a diagrammatic way, that will be very, very explanatory again, as I said. Now, theories of edema, there are several theories are there. Mostly undergraduates, we don't ask them, but PGs very, very commonly we are asking. There are different theories are there. One is the underfill theory, overfill theory. If you don't know anything, actually just mention them. There are theories like underfill theory, overfill theory that will give you impression for the examiner who are correcting your theory. But for your understanding, whether you write it in examination or not, these are the things how like. What is underfill theory says? When there is a renal perfusion is decreased because of hypoalbuminemia, it will stimulate the RAS mechanism, renin angiotensin aldosterone system. So when the renin angiosystem, what will happen? It will reduce the intravascular volume. It stimulates the antidiuretic hormone. So instead of passing the urine, more water is retained actually, because thinking that the body requires more fluid. So though the fluid is not lost to the outside, it is only transcellular fluid is there, but body thinks the patient, the person requires more fluid retention because the inside the vessels there is not much of fluid. So this is the mechanism of underfill theory. What is the primary mechanism is the radiation, the renal perfusion. They thought it is like this. The overfill theory, this explains in a different way. It is because the primary problem is the defective excretion of the sodium and water from the body. So that's why water is retained. That is, the preload is increased. Absorption of sodium and water is from the renal tubules, and more water is absorbed actively from the this problem. So that is the originating factor. So final cause nobody knows actually. More the possibilities, or maybe combination of both. So these are the basics of underfill theory and overfill theory. And there is a third mechanism also mentioned. There is enhanced peripheral circulatory permeability, almost like your dengue. What is happening is that increase the permeability of the albumin is lost because of the capillary permeabilities at the disturbances, as if just like in a case of a dengue or fevers like this actually. Okay, there are three mechanisms what I mentioned. And what else? Because of the proteinuria. Okay, you lost protein. So what? Makes it because ultimately some globulins are also maybe less, that patient becomes prone for infections. And when the lipoproteins are lost, the hyperlipidemia develops. Actually, hyperlipidemia, how it develops, we'll see in the next slide, and it may lead to atherosclerosis. When the calcium binding protein is lost, hypocalcemia manifests in the form of a hypocalcemia clinical manifestations or even bone abnormalities. As I said, the thickened blood because of the intravascular volume is reduced, hypercoagulability because of the loss of protein C and protein S and also the apoproteins. So hypercoagulability will lead to thromboembolic phenomena. Hypertension related to fluid retention usually happens in the nephrotic features. Edema of the gut or that mesenteric edema, all these things may produce absorption of the various proteins and actually nutrients that will lead to malnutrition. And the transcellular fluid accumulation will lead to ascites and pleural effusion and all these physical and problems. Actually, the mechanical obstructions and actually breathing difficulties and all these abdominal discomforts, all these development. Then hyperlipidemia. We said the third feature of the nephrotic syndrome is hyperlipidemia. So how it is? Mostly it is a very low density lipoproteins are increased, and triglycerides levels are decreased, or even albumin level is less than 1. Whenever the albumin goes very low, the triglyceride also becomes decreased, but VLDL content is increased. So what is the probable mechanism? How it happened? First and foremost, the conversion of the VLDL to LDL is done by lipoprotein lipase. So because I said lipoprotein lipase is also a small molecular protein. So in the absence of this, conversion of the VLDL to LDL is being interrupted. So when this interruption, VLDL levels increase. That's how what I said is revealed. The loss of apolipoprotein ApoC3 in urine, again that is also conversion. This helps in the hyperlipidemia. But high density lipoproteins are decreased. Please remember, it is also selective. It's not all proteins are not decreased. And in the absence of this, what happens? The lipoprotein synthesis, when the lysis is decreased, synthesis of lipoproteins is increased. That again add to the hyperlipidemia. And there may be abnormalities in the regulatory enzyme like lecithin cholesterol acyltransferase and cholesterol ester transferase. So in the absence of a lipoprotein lipase. So these are the 2-3 mechanisms you must be able to know why the hyperlipidemia has developed. I have been telling actually hypercoagulable state, especially it happens in the 2 to 5% of the children. Whenever the albumin levels fall below 2 grams, the chances of hypercoagulable state. Why? Again, one is the stasis because of the concentrated blood. Stasis itself may cause hypercoagulability. As I said, losses of antithrombin 3, factor 9, 10, 11, and thrombin activity increases. In the absence of this, thrombin activity increases. And fibrinolysin process also affected because the loss of protein C, protein S, and activity of the levels decreases. There is hyperfibrinogenemia. Maybe it's relative or real. Platelet activation also increased, and all these will lead to hyperlipidemia. Hyperlipidemia itself may cause hypercoagulability. So combination of hypovolemia, immobility is not moving also increase, and chances of infection. All these things increase the possibility of a thromboembolic phenomenon. Why a child with a nephrotic syndrome more susceptible to infection? That is because all these complications are the effects of the nephrotic syndrome, must be known. The commonest infections are cellulitis and spontaneous bacterial peritonitis and bacteremia. So actually, the spontaneous bacterial peritonitis, commonest cause of death in case of nephrotic syndrome. You know, nephrotic syndrome per se doesn't kill. If at all a child with nephrotic syndrome has happened, mortality has happened, that is because of the spontaneous bacterial peritonitis, especially by capsular organisms like pneumococcus. Please remember there is a quiz question, and also most of the viva question people ask what is the cause for nephrotic syndrome, what is the major cause of fatality. So what is causes is complement cascade is affected in this actually predominantly C3 and C5 are lost, and alternative pathway for practice B and D also lead to impaired opsonization. So impaired opsonization, these all those capsular microorganisms which are destroyed by opsonization process, they rampantly grow. So increased risk of infection by encapsulated organisms like pneumococcus. So especially pneumococcus. So pneumococcal infection, that's why vaccination for the pneumococcal vaccine is very, very imperative for these people. So spontaneous peritoneal bacteritis, please remember that, very, very important. Hypocalcemia, as I said, because of the loss of calcium transfer binding protein is lost, and also urinary loss of vitamin D binding proteins are also lead to bone mass may be decreased and bone resorptions. And also this may be because of our treatment also. Steroids, you know, long duration, if you give steroids, what will happen? The bone resorption occurs. All these may lead to hypocalcemia. So when it comes to differential diagnosis, you must know other causes of protein losing from the body. They also may manifest as in NSRK, protein losing enteropathies, hepatic failures, because the causes of NSRK are cirrhosis of liver, congestive heart failure, acute chronic glomerulonephritis, and nutritional causes of protein malnutrition. These are the, whenever a child presents with the NSRK, whatever the cause of, even if the malnutrition, I have kwashiorkor also, the differential diagnosis is this one: nephrotic syndrome, there is protein losses from the malnutrition, congestive heart failure, and hepatic causes is cirrhosis of liver and protein energy malnutrition. Just a word about congenital forms. There are Finnish type, Danish syndrome, Frazier syndrome, Nail patella. Finnish is a mutation of nephrin genes, NPHS S1 and S2 genes, which codes for nephrin and podosin is the glomerular proteins. Danish is a diffuse mesangial sclerosis. Happens is also genetic defects actually. Frazier syndrome will lead to focal segment glomerular sclerosis. Another syndrome is Nail patella syndrome. Much about them not necessary. Secondary also, so nephrotic syndrome also may secondary to that means it is congenital, but not from the genetic causes. This happens when the in utero infection, like a cytomegalovirus resist to the mother. So the fetus is infected with these diseases like hepatitis and all these in vitro, the fetal infection also met with glomerulonephritis, because secondary glomerulonephritis, I said in the children also, it's the same thing happens in the fetus also. Infantile SLE, because mother having SLE, the fetus also may get SLE and develop nephritis. And mother is exposed to the heavy metals and mercury, again that fetus may be affected. These are also congenital nephritis syndrome, but not genetic forms actually. These are the possibilities. Now, what are the investigations you do? Clinical features you have seen. The remarks are urinalysis. You see 3+ proteinuria and 3 consecutive days by DIPSTICK. So what will happen? That is the diagnostic feature. 3+ or more and 3 consecutive days, or spot urine test more than 2. As I said, spot urine test. 24-hour urine test, if you can collect and see if it is more than 40 milligrams per square meter per hour or 50 milligrams per day, also is diagnostic. Persistent microscopic hematuria may be there. This is not a diagnostic feature, please remember. And Maltese cross and lipase cast may be seen. This is actually a highline cast like thing. I will show you the diagram later. CBC, not a diagnostic for nephrotic syndrome, but you can see the possibility of any associated infection causing this. Blooduria, transient elevation may be there, but not a significant one. Electrolytes disturbances may occur because of dilution hyponatremia. Persistent elevation of renal parameters indicates non-minimum change disease. Please remember. Otherwise, usually electrolytes are within normal limits. Serum albumin, usually the hypoproteinemia definition itself less than 2.5 grams. Serum cholesterol, as I said, more than 200 milligrams. And ultrasound, just to rule out what is the size of the kidney and how is the echogenicity, whether there is effusion is there, pleural effusion, pericardial effusion, and how much it is, all these things. So if it is minimal effusion, you are diagnosed only by ultrasound. Chest X-ray is mandated because tuberculosis is very common in children, and if you rule out the sputum, if in the clinical situation it demands, you go for all this AAB test and Manto test and all this. Okay. So this is how appearance of hyaline cast. So the small cells are there, but most of it is just a precipitate of a hyaline. So this is how in the microscopy you see hyaline casts. Second line investigation, they are not routinely necessary. The clinical signal, for example, an adolescent comes or a persistent steroid resistant nephrotic syndrome is there. Such cases, you need for the complement levels, whereas anti-streptolizing titers because the post-streptococcal nephritis, hepatitis B and hepatitis C, surface antigens, you can look for the antibodies for HIV antibodies or elevated transaminases, especially with the post-hepatitis of this. Complement C3 and anti-nuclear antibodies, anti-DS antibodies, which are specific for SLE. So if you are suspecting membranous proliferative glomerulonephritis, then you have to do all these tests. Genetic mutation analysis is the latest one. Now the genetics have developed. So to see primary steroid resistance in cases, straight away, first from the beginning itself, the patient is resistant to steroids. So such cases, genetic studies are necessary. And when there is syndromic features are also necessary. Onset of nephrotic syndrome below 1 year, that means mostly congenital nephrosis. So you have to know the genetic problems, whether it is a Danish rash or Frazier syndrome or something. Or if there is a family history there also genetic studies are important. So these are all the second line therapy. And one second line therapy we left off. What is this? Biopsy. Renal biopsy routinely not indicated. Renal biopsy indication is you can classify them in the beginning itself or subsequently. So in the onset itself means, as I said, whenever the incidence is less than 1 year or first time appearance beyond 12 years, because commonest is between 2 to 5 years. So some overlap maybe 6 or 7 years is all right. But first time child presenting with a nephrotic syndrome which is up to 10 years is very, very unusual. So these are the indicators for renal biopsy. Or child presents with renal biopsy with acute kidney injury. The KK is nothing but a new name for the renal failure, acute renal failure. So we call it the acute kidney injury. So if such features are there, with very high blood creatinine and all these things. So steroid resistant. What is steroid resistant? We will define later on. So in such cases, biopsy is necessary. Renal failure is there, but not attributed to your hypovolemia. So some reason that means if there is AKI, you have to do AKI. Suspected secondary causes like SLE and HSV. So the clinical features, rashes and butterfly rashes, adults in girl, all these things, whenever there is there, or if HSV, pediatric, not rashes, but if there is a you have to go for a biopsy, all these things. So sometimes biopsy may be necessary after the treatment has started. Whenever you are thinking ఇమేజెస్ అది క్లోజ్ చేస్తే అది క్లోజ్ చేయమంటా ఉంటాం
సూర్య వచ్చిందిలే వచ్చింది
ప్లస్ వచ్చింది మరి ఎంతటి కడుతుందా మాది రేటు అది రేట్ వచ్చింది షేరింగ్ ఇక్కడ ఉన్నారా మరి లేదా ఎంత తెలుసు Hi guys, are you there? Hello.
Yes, sir.
Sorry, the net problem is there. They're disconnected. Up to what slide you heard? Actually, I don't know when it got disconnected. Did you investigation? Did you see the first line renal biopsy? I was talking. Did you see that or not? One of you please tell me. Jyoti Prakash. Hello. What is the last slide? Hi guys. Hello, everyone.
Yes, sir.
Are you there?
Yes, sir.
There is problem with the sorry with the disturbances. Network is giving trouble. So up to what slide you heard? I don't know actually. Where were you stopped actually? You remember? Did you see the renal biopsy? One of you please tell me. Jyoti Prakash.
Second line
Hello.
investigations.
Yema.
Second line investigations.
Secondary investigations. Were you there? This is
Yes,
a
sir.
biopsy.
Yes, sir.
Somewhere around talking about the biopsy. Can you see the screen now?
Yes, sir.
Okay, I will start from here actually. I will say because most important treatment part is left off actually. I try to cover vascular. So this was a telling the out of secondary investigation, the renal biopsies there is specific indications for the first onset and also for subsequent. So if at all child is less than 1 year, if there is features of renal failure are there. Anyway, I'm sharing this PDF in the slide share. All of you can download and read it later on. So we'll come to the most important part of the management now. So we'll do the initial investigation is confirm the diagnosis, to confirm the typical versus atypical features, rule out any secondary cause because infections or any tuberculosis or such things because we have to give steroids, and rule out any complications, and also educate the parent about the long duration of the treatment that you have to give and how the child has to be maintained. So basically, the supportive therapy is diet, edema, and vaccination. The second is a specific therapy. So you will remember this what are things expected. Management principle is for admit the child, exclude infections, wait for the spontaneous remission. You can admit the child is healthy. Treat infections, initiate your supportive therapy, and start steroid therapy. Supportive is these three things I was telling you actually. So what do you mean by diet? It's a balanced diet actually. Adequate protein is enough. No need for a high protein diet actually. Whatever protein you give, it will go. So adequate protein, 1.22 grams maximum. Not more than 30% calories from the fat. Usually balanced diet means 30% calories. So avoid saturated fats. Only thing is salt restriction is very important. Maximum 1 to 2 grams per day for those with persistent edema. There's a salt restriction is very important. Ensure physical activity that itself may reduce the edema sometimes. Otherwise, the stress is making the thromboembolic phenomena increases. Calcium and vitamin D supplementations are necessary. How do you manage edema? Salt restriction itself is enough. Diuretics not routinely because already there is a vascular hyperviscosity is there. So be careful very well whenever you give diuretics. You be very careful. Furosemide you can give, chlorothiazide, spironolactone. These are things why doses are also given. And 20% salt-free albumin, specific conditions. I will talk to it later on. Okay. Then some important terminology. This is very, very important whenever you go to the clinics of the nephrotic syndrome. So what is a remission? Remission means urinary protein excretion less than 40 milligrams per square meter per hour until you achieve for consecutively 3 days. Only then only the remission is happened. So these definitions you must hear by heart. Usually in the clinics, examiners will ask you these questions. What is the response? Response means attainment of this response that is less than 40 milligrams per meter per hour. That is the remission. Attaining of the remission in the initial 4 weeks. Once you start treatment, you don't wait for actually 2 months or 3 months. Within 4 months, you must be able to that remission has to occur. Then only called as a response. Relapse means after having responded, urinary protein excretion more than 40 milligrams per square meter per hour or 3 plus by dipstick on a 3 consecutive days again while the child is on treatment itself or during treatment or after treatment, whatever it is. That is called as a relapse. Frequent relapse, such type of relapse, there is more than 3 plus urines occurring more than two or more within 6 months or total 4 more than 1 year. So these are the definitions. Frequent relapse definition very often asked. Most of the clinics they will be asked. Definitely will be asked nephrotic syndrome. So frequent relapse definition is very, very important. What is the steroid dependent? Occurrence of 2 consecutive relapses during steroid therapy, or once you stop the therapy within 2 weeks the relapse happened. That means within 15 days, although you got a remission, it is coming back again. That is called as a steroid dependent. Every time you stop therapy or while you are treating itself, The 2 consecutive relapses during steroid therapy is called as steroid dependency. And steroid resistant definition is no remission after 4 weeks, because we expect remission means within 4 weeks, I said. So beyond 4 weeks, no response. The daily therapy of the prednisone, in spite of the 2 milligram per kg high dose, in spite of that, no response, no remission, that is called steroids. So this is the algorithm given by IAP, very, very important. And in the examinations, it will give you full marks, because 10 marks are there. If you don't write anything, you draw this one, you'll get full marks. I'm assuring you. The treatment of nephrotic, if they ask you, just draw this flow chart, very, very important. So the first episode, that means it is not a relapse. Start prednisone 2 milligram per kg for 6 weeks and followed by 1.5 milligram per alternate days for 6 weeks. So this is the definition. The treatment ultimately accepted now IAP also. So initially 2 milligram for 6 weeks, then 1.5 on alternate days. This is a single day, or this is an alternate days. If there is a response, that means the patient responds, but occasionally he may get a relapse. So the relapse also treated same way, just as in the case of this thing. So that means 2 years back I had, sir, again I am getting now, or 1 year back I had, the child is again after 1 year, in between the child is okay. That is an infrequent relapse. You treat it as if it is a fresh attack. Frequent relapse, as I said, within 15 days again child is responding, or 2 times during the treatment itself. So such frequent relapses, so refer for evaluation, or alternate day prednisolone therapy may be necessary, and then you have to measure how much prednisolone is necessary to control it. So if the dosage is less than threshold is 0.5 to 0.7, that means low dose prednisolone is maintaining that. So you continue for alternate prednisolone therapy for 9 to 1.5 years also, 9 months to 1.5 years also. This is enough, frequent relapse. But the alternate therapy prednisolone dose is more than 0.5 to 0.7. That is called the high threshold therapy necessary. They are demanding even 1 milligram per day also you may have to give. Such cases, prednisolone alone is not necessary, is dangerous, because adverse effect. In addition to prednisolone, you have to add, there is a supplement other drugs like levomizole, cyclophosphamide, mycophenolate, and cyclosporine. So these are the alternative drugs we call it as. So the third wing of this is steroid resistant, that is not responding within 4 weeks, no response at all. Such people have to for evaluation, either renal biopsy or actually nephrologist evaluation, because you may have to use like the drugs like various resistant therapy drugs are necessary. The treatment line is entirely different. We are not showing this flowchart. So steroids and SSNS means specific treatment for initial episode. Just what I have seen in the previous table only, I'm just giving it clearly. 60 milligrams per square meter 6 weeks as a single dose, and alternate days 40 milligrams per square meter. Now square meter doses are more important than per kg body weight. Here we mentioned 2 milligram per kg body weight, but in the examination always go for the square meter therapy is more accurate, because of the edema and all these things. Weight you cannot rely on this. The edema weight you cannot get child's weight at all. So surface area is always important. 60 milligram per square meter 6 weeks single dose, or 2 divided dose you can give, because large dose. After 6 weeks, another 6 weeks, 40 milligrams per meter as a single dose in the morning time as an alternate days. Total duration is 12 weeks. Irrespective, even if the patient has responded, you have to give 12 weeks. That is most important. Most of the studies have shown continuing beyond 12 weeks is not much of importance. So next, first 2 relapses are treated in the manner same as. So after 2 or 3 relapses, then you have to think of the alternative drugs. Frequent relapses. The patient is coming back. As I said, the definition already I have given. Frequent relapses, you have to give continue prednisolone for 9 to 18 months. Only thing is how much dose you are giving. If the prednisolone dose threshold is 0.5 to 0.7, only alone that is enough. So features of corticosteroid therapy are there, or the threshold value is more than 0.7 is necessary. Think of steroid sparing agents. What are the steroid sparing agents? This is the same thing actually I mentioned. Steroid holding the levomizole, cyclophosphamide, mycophenolate, tacrolimus, and cyclosporine. So this you skip it. Levomizole. Coming to levomizole is a antiparasitic, helminthic actually. Now it is a immunomodulator. That's why we give here 2 to 2.5 milligrams in alternate days for 12 to 12 months. Usually co-treatment prednisolone is also necessary. 1.5 milligrams in alternate days given for 2 to 4 weeks, and then reduced to 0.15 to 0.25 milligrams. So cheap side effects for all these alternative drugs, and in the main drug also, adverse effects are always remember. So leukopenia is the commonest one. That's why please check the counts every 2 months. Flu-like symptoms may be there, liver toxicity may be there, convulsions, things that very rarely. So leukocyte recruit you can monitor every 12 to 3 months. The next drug is cyclophosphamide, 2 mg per kg for 12 weeks. Alternate rate with prednisolone continue, and 30 to 40% response rate is there. Side effects for cyclophosphamide again, leukopenia, and dangerous thing is hemorrhagic cystitis. On a long high doses, there may be gonadal toxicity and malignancy. So these are here also monitoring of the blood counts are important, and urinary examination is also important. Mycophenolate maleate, actually very good drug, 600 to 800,000 milligrams, very costly drug. Only the tapering doses with the prednisolone with the 6 months. Side effects are minimal actually, GI and gastrointestinal, occasional leukopenia. Any leukocyte count again 1 to 2 months you have to keep on checking. Treatment should stop if the leukopenia occurs below 4,000. Calcium urine inhibitor drugs. These prevent T cell activation through inhibition of the calcium urine induced interleukin gene expression and stabilization of the podocyte actin and the cytoskeleton. This is how they act actually. The examples of calcium urine inhibitors are, one is cyclosporine, dose is 4 to 5 milligrams, and side effects are hypertension, cosmetic changes, gym hypertrophy, and hirsutism. Nephrotoxicity occasionally, elevated transaminases. The second drug is tacrolimus. Tacrolimus dose is 0.1 to 0.0 milligrams. Side effects are hypoglycemia, diarrhea, and rarely neurotoxicity. Again, the mechanism is prevention of the calcium urine induced interleukin 2 gene expression. These are the just a summary of all the 3 drugs. Actually, I'm not going into that. Treatment of dyslipidemia. What do you use? Sometimes they say dietary fat intake limitation is enough. Cholesterol intake should be reduced less than 300. Statins and fibrates and bile binding agents like cholestyramine, probiotics are sometimes may be necessary. How do you manage thromboembolism? Anticoagulants like heparin, low molecular weight heparin also. Fibrinolytic agents like plasminogen activating, streptokinase, urokinase. If already there is a thrombotic phenomena is there. For prevention, warfarin is used for longer periods, may be necessary as a long 6 months also. And other medications, sometimes ACE inhibitors may be necessary for proteinuria. HMG coenzyme, as I said already, for cholesterol. Albumin infusion, controversial. Sometimes there is albumin, severe abdominal pain, hypotension, severe oliguria, renal insufficiency. You may use 20% albumin in infusion. And latest development is rituximab. It is a chimeric anti-CD20 antibody, monoclonal antibody. It causes FC-mediated apoptosis and cell lysis of B cells through complement-dependent and as well as independent mechanisms. Plasmapheresis may be necessary. Galactosis, now one of the, especially in fact, focal segment glomerulosclerosis. Zinc supplementation is avoid to prevent various complications, especially 10 milligrams per day. And one segment we didn't discuss at all is the initial steroid resistance. So especially it happens in pathological forms, abnormal forms actually. So trial of methylprednisolone therapy may be necessary. Cyclosporin A, intravenous immunoglobulin, and mycophenolate. These are the drugs for the initial steroid resistance. Immunization very important. To give pneumococcal vaccination, influenza vaccination is also advisable every year. Live vaccines are contraindicated. Please remember when you are giving steroids. Immunize not only the child, household contacts also with live vaccines, because any infection of them, they may give the child also. So better the caretakers also be free from infections. And following varicella contacts, give all those non-immuno children and immunosuppressive agents. Varicella zoster immunoglobulin if it is available. Fortunately, India we don't have it. So what are the complications? Complications you divide due to disease, due to treatment. Sometimes the examination question may be only in a complication of nephrotic syndrome. So due to disease, malnutrition, infections, thromboembolic phenomena, deficiencies of all these elements, laryngeal edema rarely. So infections, causes of why infections, I already told you, immunosuppression, all these things, peritonitis, pneumonitis, all the types of infections I said. Complication due to treatment. Complications of steroids, very commonly asked, whether it is here or asthma, whatever it is. So you remember at least out of these 10, 4 or 5 extempore you must be able to say. Cushingoids in development, hypertension, osteoporosis, susceptibility infection, growth